Myopic macular holes represent a small fraction of all types of macular holes, but they are unique in regard to the pathogenetic mechanism and the real surgical challenge that they represent for retinal surgeons. And we will try to give an update on pathogenesis and surgery.
The full thickness macular hole is defined as an anatomical defect in the fovea that interrupts all neuroretinal layers. The pathogenesis of macular hole arises from the remaining vitreous cortex in the macular area after the vitreous is separated. The dynamic forces of the vitreous fluid concentrate on the macular layers, causing swelling of the middle and outer macular region, with elevation and retraction of the inner retinal layers. As the swelling increased, the hole became enlarged.
The idiopathic macular holes account for most of the macular holes, about 85%.
Several classifications were proposed starting from biomicroscopy until cross-sectional OCT. OCT has now become an essential complement to biomicroscopy for the diagnosis of macular disease and especially macular holes. So the gas classification now needs to be revised according to the OCT features. More stages were added in order to better assess the relationship between the vitreous body and the retinal surface. This feature is essential while performing surgery, and it is linked to the optimal exploitation of vitreous and inner limiting membrane success of surgery. Godric and Tadaioni proposed a classification in 6 stages according comparing and integrating biomicroscopy features, gas classification, and OCT images. Basing OCT images, we can assess macular hole etiology in 5 main origins. The idiopathic macular hole, it is demonstrated that the dynamic forces caused by mobile posterior cortical vitreous with fluid currents exist already at early stages of macular hole development until full thickness damage. The lamellar macular hole. There are two different subtypes of lamellar macular hole, found peculiar functional aspects due to their morphological features. The tractional lamellar macular holes revealed higher visual acuity and retinal sensibility due to the relative preservation of the outer retinal layers compared to degenerative macular holes, like this case where external retina is damaged by the degenerative chronic process and result in low visual outcome. The traumatic macular hole. A review on its etiology and management discusses about the role of tangential and anteroposterior vitreomacular traction. This macular hole may also result from foveal photoreceptor atrophy following commotio retinae. The origin of macular hole in myopic eye is a complex and multifactorial process that employs tangential and axial tractions. Progression of myopic macular hole may have tangential evolution or perpendicular evolution. Macula may be affected by progressive tangential forces that first delaminate fovea and finally open a full-thickness macular hole. A second process works on anterior-posterior axis with the progressive schisis that delaminate mainly inner retina, outer retina, and whole retina until macular retinal detachment.
Therefore, the myopic macular hole is one aspect of a complex process, the myopic maculopathy, that has been classified by Ruiz Moreno as the ATN classification. It is based on three main pathological features: atrophy, traction, and neovascularization. Myopic traction maculopathy represents the tractional feature in the ATN triplet of myopic maculopathy. It affects
9 to 34% of eyes with myopic maculopathy. Retinal detachment associated with macular hole mostly occurs in highly myopic eyes. It has been suggested that macular hole retinal detachment, MHRD, is caused by tangential and anteroposterior traction due to the presence of a posterior staphyloma combined with a weakened retinal adhesion caused by retinal pigment epithelium atrophy. Therefore, there are a combination of causes: the abnormal elongation of the sclera in the posterior staphyloma, the chororetinal atrophy in the macular region, and tangential as well anteroposterior forces of the vitreous remnants over the retina. Now, let's answer one question. What are the basic principles of macular hole surgery and why they do not apply to myopic macular hole with retinal detachment?
For macular hole surgery, the benefit of vitrectomy and ERM removal is that it basically relieves vitreomacular attraction at the whole age from both anteposterior and tangential forces and induces retinal glial tissue to bridge and close the hole. These principles are known since 1990 by Kelly and Wendell. Gas tamponade helps keep the hole closed by bridging the hole edge more closely, preventing fluid from the vitreous cavity to flow through the hole. The rationale of internal limited membrane peeling in 1997 by Eckhart is the removal of residual adherent vitreous cortex remains, thereby increasing retinal compliance. The inverted flap technique, developed by Michalowska in 1910, is based on the rationale that Muller cell fragments reside in the ELM, and they can produce cytokine to induce proliferation of glial tissue. The inverted flap acts as a scaffold, stimulating glial tissue proliferation on the surface and growing into the hole and retina. The ELM flap serves also as a barrier, preventing entering of fluid from the vitreous. The creation of this microenvironment encourages photoreceptor to move into the correct position. Following this, a number of new techniques were proposed. The autologous transplantation of internal limited membrane, mimosine, the autologous lens capsule transplantation by Chen, the autologous retinal free flap transplantation by Greenwald, a human amniotic membrane by Ritson, and finally, Tamburelli describes the use of iris transplantation.
All these concepts that we realize are quite effective in surgical treatment of idiopathic macular hole can be applied to myopic macular hole with or without retinal detachment associated.
The answer is only partially. As we have understood in idiopathic macular holes, the main or the first moment is exposure of hole borders to vitreous fluid, promoting entering and retinal layer separation. In myopic macular holes, besides this mechanism, other forces act over a long period of time, even years. They induce hole developing and, in few cases, retinal detachment. Forces are exerted by the vitreous and by the sclera. They might act simultaneously or even independently from each other. The vitreous can pull the retina in absence of scleral deformation, and the sclera can act in absence of the vitreous, such as in vitrectomized eyes or in eyes that already showed a spontaneous vitreous detachment.
The array of available surgical procedure can be divided in techniques promoting a position of the macular hole borders by internal or extrascleral surgery. A position of the hole borders by internal surgery alone achieves a lower rate success as compared with an extrascleral procedure that can obtain 93% of all closure. Vitrectomy alone has a lower success rate because procedure easily performed in normal eyes, such as ELM peeling, are more complex in myopic eyes due to the fragile structure of myopic ELM and difficulties in staining and visualization. Moreover, vitrectomy alone cannot overcome the excessive elongation of the posterior staphyloma that is directly addressed with extrascleral procedure and posterior buckling. Finally, APR atrophy in the staphyloma further accounts for surgery failure. Macular buckling is usually a difficult procedure because of difficulties in placing suture in the posterior pole of an eye on an extremely thin sclera. In the course of the year, several procedures have been suggested with rigid silicone, with different types of specifically designed devices by Ando in 2007, by Devin and Morin, or with rigid internal suture and soft external protection, or with internal fiber optics for proper positioning when coupled with vitrectomy. More recently, new procedures are available and their use in these difficult cases are under investigation. The additive techniques with autologous tissue, or more recently with heterologous amniotic membrane, or with iris transplantation. Thank you.
In the last year, we have used in 8 patients with the macular hole retinal detachment iris as autologous tissue transplanted over the RPE or the bare sclera in case chorioretinal atrophy was present, mainly as a plug to fill up the opening and to repair macular hole retinal detachment and posterior pole retinal breaks. An inferior iridectomy is performed, iris stroma and iris pigment epithelium is harvested and placed in the macular hole under silicone oil to prevent free floating of the tissue in the vitreous cavity. In the follow-up, retina remained dry and the iris plugged firmly the hole. A second iris patch can be harvested and placed in extrafoveal holes in cases of multiple simultaneous holes. Iris provides a sufficient thickness to plug the entire height of the hole and the staphyloma. Iris patch is placed in the dried hole and properly positioned with the pigment epithelium facing up toward the vitreous cavity. The reason why we decide to use iris as a transplanted tissue is because it is easily available, is autologous, and the pigment epithelium share the common embryologic derivation with the retinal pigment epithelium, and there are in vitro evidence that may transdifferentiate from iris to retinal. This in case it is placed in the proper microenvironment, such as the subretinal space.